Welcome to Clinical Capsules from TRC Healthcare, your trusted source for practical, evidence-based updates. On this episode, Associate Editor and Clinical Pharmacist Vickie Danaher reviews how the new oral version of Semaglutide is changing how clinicians think about GLP-1 medications for weight loss. She walks through how it compares to injections, what patients need to know about administration, and when switching dosage forms makes sense. And an excerpt from our popular Pharmacy Essential Updates webinar series. This podcast offers continuing education credit for pharmacists and pharmacy technicians. Please log into your pharmacist letter or pharmacy technician's letter account and look for the title of this podcast in the list of available CE courses. None of the speakers have anything to disclose. Catch new episodes of Clinical Capsules every second and fourth Tuesday, bringing concise, actionable insights from TRC experts straight to your ears. With that, let's get started.
We know that the injectable GLP-1 medications have become pretty popular over the last few years for obesity, type 2 diabetes, and other conditions. But the fact that we now have an oral GLP-1 agonist for weight loss is a big change. And like our article says, patients are asking about prescription semaglutide tablets, the first oral GLP-1 agonist FDA-approved for obesity and overweight. These new tablets, which go by the brand name Wegovy pill, are essentially the oral version of injectable Wegovy. So the drug itself, semaglutide, isn't new. But this means that we now have multiple different FDA-approved semaglutide products that we may get prescriptions for or that our patients may be getting or asking about. And it can be kind of tricky to keep them all straight. So for obesity and overweight, we have the new oral semaglutide tablets, which we're going to focus on today, which are taken daily, as well as the subcutaneous injections, which are given weekly. And both of these products for weight loss go by the brand name Wegovy. And then for type 2 diabetes, we have the daily oral tablets called Rybelsus, as well as the weekly injection Ozempic. And we're used to dispensing these since both of them have been around for a few years now. But then it was also recently announced that Ozempic oral tablets have been FDA approved for type 2 diabetes. But these aren't planned to launch until Q2 of this year. So having all these options now means there's going to be a lot more questions about how all these products compare and which option may be best for a patient. So let's talk through how this might come up in practice with the patient case. Our patient today is Jay. He's 42 years old, and he's been taking injectable semaglutide 2.4 milligrams weekly for obesity for the past few months now. Jay says he's lost about 15 pounds since starting therapy, and overall he's tolerated it pretty well. But he dislikes giving himself weekly injections and wants something easier. He also wants something easier to transport since he also frequently travels for work. Jay says he's heard that there's now a pill version of his medication, and he asked whether he should switch to that instead. So how would you respond back to Jay? What do you think he should know about the semaglutide tablets to help him decide about switching? And we'll come back to Jay throughout our discussion. But first, let's do a quick review of how GLP-1 agonists help with weight loss. So GLP-1 agonists mimic our body's natural GLP-1, which is an incretin hormone released from the gut after we eat. And under normal conditions, when food enters the intestines, GLP-1 is released and triggers several important responses. For example, GLP-1 increases insulin secretion from the pancreas. It also suppresses glucagon, the hormone that signals the liver to release stored glucose. But for weight management, two other effects matter most. GLP-1 slows gastric emptying, so food leaves the stomach more slowly. And it also reduces appetite by acting on receptors in the brain involved in hunger and satiety. So GLP-1 agonist medications activate these same receptors, helping people feel full sooner, staying fuller longer, and ultimately eating less. They also still help lower postmeal glucose, but their appetite regulating effects are a big reason why they lead to clinically meaningful weight loss. But the GLP-1 agonists for obesity have all been injectable up until now. And that kind of makes sense if you think about the fact that GLP-1 is a peptide. So it's a short chain of amino acids. So it would normally be inactivated and broken down in the stomach, just like proteins are broken down in the stomach. But the new oral semaglutide for weight loss is formulated with an ingredient called sulcaprosate sodium, or SNAC, to prevent breakdown in the stomach. SNAC is a fatty acid derivative that acts as a carrier, and it's designed to help semaglutide survive stomach acid and pass into the bloodstream. It also acts as an absorption enhancer, protecting the medication from degradation and boosting absorption. And SNAC is the same mechanism used in Rybelsus, the oral semaglutide tablets for type 2 diabetes. So, how well does oral semaglutide for obesity work? Be aware that using oral semaglutide 25 milligrams daily for 64 weeks leads to about 11% more weight loss than with placebo. So, this comes out to be about losing 26 pounds for a patient who weighs 234 pounds. Explain that this seems similar to the weight loss seen with injectable semaglutide 2.4 milligram weekly for obesity or overweight. And it's more than most other oral weight loss medications. But there aren't any head to head trials yet. So, to help put this in perspective, let's talk for a minute about the efficacy of certain treatments for obesity and overweight. So, oral phentermine alone leads to about 8 pounds more weight loss than placebo. Naltrexone bupropion ER, about 9 pounds. And phentermine topiramate ER, about 19 pounds. And then either semaglutide product for obesity, so either the oral tablets or the injectable, lead to about 26 or 27 pounds more weight loss than placebo. But injectable tirzepatide or Zepbound achieves more, about 41 pounds more weight loss than placebo over a year in patients without diabetes. When thinking about meds for weight loss for our patients, we also want to tailor the selection based on things like cost and access, the patient's other comorbidities, and other medication benefits. So, for instance, the new oral semaglutide for obesity is also approved to reduce the risk of cardiovascular events, such as strokes or heart attacks, in patients with cardiovascular disease and obesity. And this is similar to the semaglutide injection. But oral semaglutide isn't yet indicated for metabolic dysfunction associated steatohepatitis, or MASH, which is a severe form of fatty liver disease. And the injection does have this indication. Also, point out that the Wegovy oral semaglutide tablets have pretty tricky administration, like the Rybelsus tablets. For example, emphasize that oral semaglutide must be taken daily upon awakening on an empty stomach. It must be swallowed whole with a sip or no more than 4 ounces of water. And then patients must wait at least 30 minutes before having the first food, other beverage, or oral meds of the day. Not following these steps can reduce the absorption and efficacy of oral semaglutide. So, these are really important points that should be shared with patients picking up oral semaglutide at our pharmacies, or patients like Jay who are thinking about switching from injectable to oral semaglutide. When patients do get oral semaglutide for obesity, keep in mind that it has similar GI side effects as injectable semaglutide, so things like nausea and upset stomach, and help ensure proper dose titration to help limit these effects. Most patients getting oral semaglutide for weight loss will start with 1.5 milligram semaglutide tab daily for 30 days, and then increase every month to 4 milligrams for 30 days, 9 milligrams for 30 days, until the 25 milligram per day maximum is reached. And then, of course, the $1 million question with GLP-1 agonists is cost. And like we often see prior auths with injectable GLP-1 agonists for obesity, we should expect prior auths for the new oral semaglutide too. Oral semaglutide for obesity costs about $1,350 per month, which is the same as the injectable. But patients may be able to get these prescriptions for less with manufacturer savings programs or direct to consumer programs. Now, with all this in mind, let's go back to our patient case with Jay. Again, he's currently on injectable semaglutide for weight loss, but he says he wants something easier to use and he asks about switching to the tablets. You can let him know that the oral formulation offers similar weight loss benefits and has similar side effects, but it comes with pretty strict administration rules. Jay would need to take it every day, first thing in the morning on an empty stomach, with no more than 4 ounces of water. And then he'll need to wait at least 30 minutes before eating, drinking, or taking any other medications. So, if Jay is motivated to follow these dosing instructions and the daily timing of the medication fits better into his travel routine, switching may help improve adherence. But if mornings are unpredictable for him, staying on the weekly injection might actually be a little easier. So, the bottom line in this case is the switch may be reasonable, but only if Jay can reliably follow the strict daily dosing requirements with the oral medication. Now, let's say that Jay does want to go ahead and change dosage forms. How should we advise on handling switches between the semaglutide injections and tabs? Explain that patients on injectable semaglutide 2.4 milligram weekly who prefer an oral med, like Jay, may switch to oral semaglutide 25 milligram tablet daily 1 week after stopping their last injection. On the other hand, if patients are taking oral semaglutide 25 milligram daily and either they can't tolerate the tabs or they need additional weight loss, they may switch to semaglutide 1.7 milligram injection weekly the day after stopping the tabs. In addition to switches, we want to watch for patients combining oral and injectable GLP-1 agonists. Sometimes patients assume that if one GLP is good, then two must be better. But there's no evidence that combos work better to improve weight loss or glycemic control, and it likely increases the risk of side effects, especially nausea, vomiting, and GI intolerance. So, if you spot a patient on both, clarify the plan with the prescriber and make sure that only one GLP-1 therapy is being used at a time. Let's close out this topic now with a few other key pearls that we can bring back to our pharmacies. And a big one that we'll need to continue doing is paying close attention to semaglutide products and strengths. So, for example, be aware that oral Wegovy for obesity comes as 1.5 milligrams, 4 milligrams, 9 milligrams, and 25 milligram tablets. But oral Rybelsus is available in 3, 7, and 14 milligram tablets. And then the recently approved oral Ozempic is also planned to be available in similar strengths as oral Wegovy. Don't automatically substitute oral Wegovy with injectable Wegovy, oral Wegovy with oral Rybelsus, and so forth. These products aren't considered equivalent. Store oral semaglutide tablets in their original container at room temperature in the pharmacy and tell patients to store them the same way at home, since the tablets are sensitive to moisture. Now, this could also be a consideration for patients like Jay in our case who travel. He shouldn't be putting those tablets in a pill container or a pill box, and he'll need to take the original bottle with him. Also, know how to handle missed doses. Because of oral semaglutide's strict administration requirements, patients who miss a dose should skip the missed dose and just take the next dose the following day. We've also got lots of other valuable resources on our website to support you in your practice. You can use our GLP-1 and GIP/GLP-1 receptor agonist interactive comparison chart to sort through products, indications, clinical outcomes, and more. And then see our resource comparison of weight loss products to review other meds for obesity and overweight, along with their pros and cons.
Thanks for listening. We hope today's episode gave you practical insights you can use right away. Now that you've listened, pharmacists and pharmacy technicians can receive CE credit. Just log into your pharmacist letter or pharmacy technician's letter account and look for the title of this podcast in the list of available CE courses. We've linked the resources we mentioned and more on today's topic right in the show notes. Those links will take you straight to our websites where you'll find even more concise, evidence-based charts, articles, and tools. If you're not yet a subscriber, now's the time. Sign up today to stay ahead with trusted, unbiased insights and continuing education. Listeners save 10% on a new or upgraded subscription. Just use code CC 1026 at checkout. If you found this episode helpful, follow Clinical Capsules and leave a quick rating or review. It helps others discover the show. Better yet, share what you learned with a friend or colleague and let them know they can find the show on any podcast app. Thanks for listening. Stay sharp, stay current, and join us next time on Clinical Capsules.